than what we're at. Then this slide is the sac that sits round the heart and keeps the heart intact. There is called the pericardium, and that can get inflamed or cause a leakage of fluid, and that can sometimes gather around the heart, and in very rare occasions can affect the way the heart is pumping, but it's quite uncommon. I'm not going to mention much more than that. So pulmonary vascular disease really means diseases that affect the blood supply to the lungs. And before we get into what the underlying problems are that cause this, it's important to recognize what symptoms patients might get with these diseases. And there's actually quite a lot. And if we go through them, we can start at the top here. You can get breathless lying flat. That's mainly a sign of when the left side of the heart is not pumping very well. I think one of the key elements of symptoms that I look for when I'm talking to a patient is actually exertional breathlessness, i.e. walking along the flat or slight inclines that used to do no problem at all now leads to you having to stop perhaps, and going up a flight of stairs. You would normally be able to walk to the top without any problem. Now you have to stop halfway up to get your breath back. That sort of level of breathlessness. You can get some chest discomfort. That can range from something that sounds like angina to atypical pain, as we call it, which can be just flitting pain and, you know, spread throughout the chest. A cough, fatigue. I mean, that can go with scleroderma in its own right, but pulmonary hypertension with scleroderma certainly can compound that fatigability. In cases where the pulmonary hypertension has progressed and led to problems with the right side of the heart pumping, that can lead to fluid accumulation. And we can see that with swelling of your ankles. You can wake up breathless in the middle of the night. Again, that's a feature that's more in keeping with your left heart disease. And in extreme circumstances, you can start feeling like you're going to collapse, or you can actually have blackouts as well. So those are the symptoms that we as clinicians would be looking out, and you as patients should really be looking out for as well, and reporting back to us if you're starting to develop any of these. Now, when it comes to the diagnosis of pulmonary hypertension,
Brian, it's not, mine doesn't pick up the Bluetooth. I'm trying, it's on.
Right, I'm sorry. You can just play it through the phone or something. Can you hear me just now?
Yes, that's true.
Sorry about that. I'll tell you that another time. My daughter was playing a speaker down the stair and it connected to this computer, so apologies for that, folks. I'm really sorry. The wonders of modern technology, but there we go. Right, I'll try and pick it up here. So when we're talking about the diagnosis, unfortunately, this can be delayed. And despite modern screening methods and modern medicine, it still takes, on average, for a long time to actually pick up the diagnosis of pulmonary hypertension. And this is from a PHA survey back in 2020, which looked at the average time to diagnosis. And you can see here that in over 48% of patients waited over a year after first experiencing their symptoms. So that's quite a long time. And if you go back in the start of pulmonary hypertension, the average time from onset of symptoms to diagnosis was about 2 years. And we've done a UK study in the last couple of years. Unfortunately, that time is still taking about 2 years. So it's really, something that we need to try and investigate a bit earlier. And that's where the symptoms and annual screening comes in to try and help. And it also, the other worrying thing is that, a lot of patients see a multitude of doctors, a multitude of specialities before the penny drops and they think of pulmonary hypertension as a clue here as well. So what investigations might I need to look at your symptoms? That's the breathlessness and maybe the dizzy spells or the collapses. And these are the sorts of investigations that as clinicians we might offer you. So first of all, we'll talk to you and find out the history. We'll ask about the symptoms that you have. We'll ask about your past medical history. How long have you had scleroderma for, etc. Is there a family history of problems with high blood pressure in the lungs? What medicines are you on? Then we'll move on to physical examination, and that's where it's difficult in pulmonary hypertension because in a lot of cases, actually examining the patient, there's not that many features to find. Obviously, if you've got the scleroderma features, that's evident, but actually detecting the high pressure in the lungs, that can be quite tricky from just examining and listening to the heart. So that's why you need a multitude of tests to try and investigate that further. So we have non-invasive investigations such as electrocardiogram, that's an ECG, and I'm going to go through these in the next few slides to illustrate a few of them. Chest x-rays, echocardiogram, so that's called an echo for short. It's effectively an ultrasound of the heart. Breathing tests, exercise tests, and then you get into the radiology tests, and that can be from CT scan, which I'll show you a picture of, or nuclear medicine scanning, which is the ventilation perfusion scanning. These are all to look at the blood vessels in the lungs and also to look at the actual lung structure themselves. And then you move on to the diagnostic test. And again, I'm going to talk about that in a minute, which is an invasive test, and it's called a right heart catheter. And that is really the test that allows us to diagnose pulmonary hypertension. And without that, we can be very confident that there is a diagnosis, but you really need this invasive test as the gold standard diagnostic test. So this is an ECG. Many of you may have had this before. It's where you get the stickies put on your chest, and then you'll get this printout of the electrical activity in the heart. And we can see certain features on the ECG that can be suggestive of pulmonary hypertension. In this example here, there's some changes in the certain configuration of the electrical activity that would give a hint that there's something not quite right. And we can use that as an early screening test for patients when they have, breathlessness or chest discomfort. I would say one of the most critical tests in certainly the screening, but identifying patients at risk of pulmonary hypertension, is echocardiography. And that is an ultrasound-based system of the heart. So it's like pregnant women, they go along, they get the ultrasound of their tummy. We're doing the same principle, but this time over the chest. And we get some different views of the heart, and you can identify whether the right or the left side of the heart is under pressure or struggling. So that's quite an important test, and often that will be the first test that really allows us to identify that certain patients have pulmonary hypertension. So this is the images that you would get from the echocardiogram. The one on the left is a normal echocardiogram. The one on the right shows pulmonary hypertension. And what you can see is that this is compared, this area here is different from that area here. So this one on the right is dilated, it's bigger, and that's suggestive, that's the right side of your heart. I know it's on the left side of your screen, but it's actually the right side of your heart. That's just the way the images are obtained. And that is on the right hand side of the screen is bigger than it should be, suggesting that there is evidence of strain, and that's an indicator of raised pressure in the lungs. Moving on to CT scanning. So radiology is critical as well to the understanding of pulmonary hypertension, both in detecting it and working out what the cause of it is. CT scanning is where you go through this big donut, and there are multiple X-ray detectors that rotate round as you move up and down through the hole in the middle there. And that is very good at reconstructing then the detailed anatomy and images of your lungs, but also your heart. And we can get a lot of information from that area. So these are the pictures that you might get. I've drawn two lines here. The first line is the area across the aorta, which is your main blood vessel coming out the left side of the lung. This one on the right here is your main pulmonary artery, which is the one that is leading the blood into the lungs and can cause the raise, and is where we would see an effect from the pulmonary hypertension. And it's very bright on this side because we have timed the contrast when we inject it into your veins during the procedure. We've timed the acquisition of the scan to correlate exactly when we get the brightest signal in the pulmonary artery. So that gives us the most information. And then you can scroll up and down on a computer and get an idea of what's going on in the rest of the blood vessels and the lungs. Cardiac MRI, you might have heard of MRIs for backs and knees, etc. There's now increasing interest in looking at the heart under MRI. It gives a lot of structural and functional information, so that the image that I've got playing here, this is the right side, which is a lot bigger than it should be, and this is the left here as well. And you can see that there is this middle bit, which we call the septum, and we can see that that has pushes over into the left when the pressure is high on the right hand side, and that's sort of features we would be looking for in the detection of pulmonary hypertension. There are breathing tests as well. They include sitting in a box, like the scan on the right, the picture on the right, to take lung volumes and function. There's also ones in the exercise test in the left, where we might try and stress your lungs and stress your heart and try and get an idea of what happens to the heart under pressure. And that's sometimes in very mild disease, you might need that exercise test to try and identify exactly what is going on with your lungs. So these are the sorts of symptoms and investigations that we would often ask patients to go through when we're trying to work out if you have pulmonary hypertension. But what exactly is pulmonary hypertension? As I mentioned before, it's just a terminology that refers to high blood pressure within the lungs. If you want to get in great detail, the true definition is when you have a mean pulmonary artery pressure of greater than 20 millimeters of mercury at rest, normals below 19, and that the only way we can tell that definitively is when we do the right heart catheter, which I'll explain in a minute. So pulmonary hypertension is a blood pressure definition. It's not really a diagnosis because pulmonary hypertension can be caused by all sorts of problems, not necessarily a narrowing of the blood vessels. That can relate to lung disease. If there's scarring in the lungs, that can give pulmonary hypertension. So a whole host of reasons. And these tests that we've just outlined, and indeed the right heart catheter, are the key diagnostic tests to try and identify exactly what is causing that pulmonary hypertension. So you can see here that, sorry, my picture hasn't quite worked that. In pulmonary hypertension, when the pressure is greater than 20, there are different types of classification of pulmonary hypertension. Group 1, and that is the main one that affects scleroderma. So that's when we have pulmonary arterial hypertension. So remember, pulmonary hypertension just means high blood pressure in the lungs. Pulmonary arterial hypertension is where there is a specific disease affecting the small vessels within the lungs, and that's the type that's commonly seen in scleroderma. But you can also get pulmonary hypertension from other causes. I mentioned left heart disease. That's called group 2 disease. That's when the left side of the heart's not working. Group 3 disease is where the lungs are actually not working. So that's not the blood vessels necessarily, but the actual air sacs in the lungs. And that's such as the scarring that you can get with scleroderma, that can affect that. You can also get pulmonary hypertension where you get recurrent clots to the lungs. You may have heard of a thing called pulmonary embolism. That's where you get clots to the lungs, often on long haul flights, etc. And that can lead in a small proportion of patients to this condition called chronic thromboembolic pulmonary hypertension, where the clots in the lungs stay, they don't dissolve, and that leads to narrowing as well. So scleroderma can affect all of these areas because there's associations with scleroderma affecting the lung vessels, the left side of the heart, scarring of the lung, and potentially clots to the lungs as well. And if you can imagine that in scleroderma, a lot of patients have Raynaud's disease where the blood vessels to the hands are affected. In pulmonary hypertension, that same process is almost happening in the lungs. So you have on the right here a normal size pulmonary artery, but as pulmonary arterial hypertension develops, these thicken up and the cells increase in size, and the diameter or the area for the blood to go through narrows down, and that leads to this progressive change in the pressure and hard for the blood to get through. That then feeds back onto the pumping chamber, which is the right side of the heart. That heart has to pump harder, and at points it starts to struggle with that, and then that can lead to right heart failure. And we see that in patients by increasing breathlessness or swelling of the ankles. So that's this is the echo again, as we've shown already. This is the dilated right side of the heart compared to the left, and this is the septum here between the right ventricle, the main pumping chamber on the right, and the left ventricle, the main pumping chamber on the left. And this septum, when it's bowed over or pushed over into that side, is very suggestive of pressure rise in the right side. So who actually looks after patients with pulmonary hypertension in the UK? And I'm just talking about the UK. In Europe and the US, it's slightly different. But we have 7 or 8 main centres in the UK that look after pulmonary arterial hypertension. And you would all have geographically be referred to your local centre. And you can see here for Scotland, it's ourselves in Glasgow. There's one in Newcastle, Cambridge, Sheffield, and then there's a few in London and then Dublin as well. So these are all specialists that are involved in the diagnosis and also the management of patients with pulmonary hypertension. So this is the centre in Scotland. We call ourselves the Scottish Pulmonary Vascular Unit. It's based at the Golden Jubilee Hospital in just outside Glasgow. Yeah, that was it. Sorry. So I just wanted to show where we reside. Now, when you come to these centres, you'll either have had a lot of these tests done already, or we'll do some again. But one test that you probably won't have had, and that's the test that we do as specialists, is this right heart catheter. And this is the right heart catheterization here, where under X-ray guidance in the cath lab, we would insert this catheter, which you can see on the right-hand side here, into usually a neck vein under ultrasound guidance. It's like going to the dentist. You'll get some local anaesthetic, numbs it all up, and then we pop this wire into the blood vessel and feed the wire down into the heart and into the lungs and measure the pressure throughout that journey. And that's very important because the pressure changes as you go along different routes of the heart. And these measurements are very important in telling us whether you have pulmonary hypertension, and if you do have pulmonary hypertension, what the cause of that is, because we can accurately determine from that investigation whether the problem lies primarily in the lungs, or whether it's in the left side of the heart, or whether there's some other abnormalities as well. So that's why we undertake these tests. And if we find that you do have pulmonary arterial hypertension secondary to your scleroderma, what can we do about that? Well, there are lots of treatments now, which is quite remarkable compared to 20, 30 years ago, where really there was very limited management that we could do for this condition. We have conventional therapy, and what I mean by that is that we're not directly targeting the underlying problem. We're trying to treat the symptoms, and we use diuretics, water tablets, to try and get the fluid off. We sometimes use anticoagulation or blood thinners if you've got risk of clots, and some people need oxygen, particularly if you've got scarring in the lungs or your oxygen level is low. Targeted therapy are treatments that have been shown to improve the underlying pressure within the lungs, and that's often oral tablets to start off with, but as the disease progresses, which unfortunately it can often do, you may need more advanced therapy, and that can be delivered by inhalers or intravenously, and sometimes in severe cases you may need lung transplantation as well to treat this condition. So these are just some of the names that are used there for the drugs that you might need in the course of treatment of your condition. Sildenafil, tadalafil, bosentan, ambrisentan, macitentan. There's lots of therapies that are tablet-based. Riociguat's another one as well. These are often the first-line treatments that we would give to try and open up the blood vessels in the lungs. We would then move on, if the condition's progressing, to either intravenous or nebulized treatment. There are other oral agents as well called Selexipag. That's a more advanced drug now as well. And these are all coming into play and are introduced at different points of your journey with the disease, depending on what your symptoms are and how your trajectory is going. So these are tablets. I'm sure you all know what tablets look like. These are the nebulizer treatment that's often used, the Brelib device. This delivers a drug called iloprost, and these drugs are all designed to open up the blood vessels in the lung. They work as pulmonary vasodilators to try and allow the blood to get through easier and drop the pressure. If these fail, then sometimes you have to move on to intravenous therapy. And this is where the treatment becomes a bit more of a burden. And that's because this is a continuous drip that you require through a Hickman line, which is this catheter on the left that's tunneled under the skin and sits in the heart. You have a pump where the drug is delivered continuously 24/7, 365 days of the year. And although that sounds like a lot of impact on your life, and and it can be at the start, it is actually very well tolerated and can be quite a dramatic improvement in your symptoms. And we still regard Flolan as perhaps the gold standard therapy, but we don't go there straight away because of the burden involved with having the Hickman line. So last few slides, going to talk about, before we have the question and answer, but talk about screening. So there's no doubt that in certain conditions, there is an increased risk of developing pulmonary arterial hypertension, and scleroderma is one of those groups. And therefore, in those groups, early detection is important because there is some evidence that the earlier you treat, the better the outcome. And therefore, trying to detect that using various modalities such as echo, ECG, blood tests is important. It's very similar to the national screening services we have with cervical cancer or breast cancer, mammography, etc. It's the same sort of principle where we try and detect a disease earlier and intervene at an earlier stage with hopefully having a better outcome. Okay, so that's pulmonary hypertension. Just a couple of slides on left heart disease. So as I mentioned, there is the right and the left side. So the right side here is in the purple, the left is in the red. And what this distinguishes is the circulation between the lungs and the rest of the body. But scleroderma can affect both sides. It can affect the right side through the pulmonary hypertension that we've talked about, but can also affect the left through scarring of the actual lungs, scarring of the left side of the heart, and that can cause the left side of the heart to struggle a little bit as well. The consequence of that is that it leads to a build-up of fluid, and that build-up of fluid can affect the lungs, and so you can become breathless. And the symptoms that we often see with that are when you're lying flat in bed, you get breathless, and many patients come in and say, I'm having to sleep with 3-4 pillows, and that's because they're getting breathless lying flat, or they wake up in the middle of the night short of breath as well. And these are important symptoms to let your doctor know about. They're usually managed by the heart doctors, cardiologists. Mainstay of treatment are water tablets to get rid of the fluid, but there's lots of other new drugs that are coming on, or more established drugs as well, such as the beta blocker ACE inhibitors that many have used for high blood pressure in the past, and you can use that to try and improve the heart function as well. So in summary, hopefully I've tried to show you that pulmonary hypertension just means high blood pressure within the lungs. You have to then try and get into a bit more in-depth investigation to try and exactly work out why you've got it. And in scleroderma, that can be for a number of reasons. It can be due to this pulmonary arterial hypertension, which is the small blood vessels in the lungs that get thickened. It can be due to the left side of the heart being scarred and not working properly. It can be due to the lungs where you get scarring, or it can be due to the increased risk of clots, for example, as well. And the only way you can work that out is to do quite extensive investigations, as involving many of the tests that I've outlined previously in this talk. And it is very important that you get screened for this, and echocardiography really is one of the main tests to do that, and either your rheumatologist, cardiologist, or respiratory physician should be trying to arrange that for you to try and pick up this disease at an earlier stage. Okay, so that's me finished. Apologies for the glitch halfway through there. Thanks for putting up with that. And I'm happy, Ollie, to take any questions that you want to throw at me.
Thank you very much indeed, Dr. Church, for that excellent and very, very informative and educational presentation all about pulmonary arterial hypertension. So we'll move on to the questions, of which we have many. So thank you so much to our community for submitting the questions. Going to start off with a question from Tanya, a two-part question. Tanya asks, is it true that patients with the anti-centromere antibody have the highest likelihood of developing pulmonary arterial hypertension? And the second part, what can we do to preventatively minimize the risk of developing it?
Yes, so great questions. And Tanya's absolutely correct that anti-centromere is the main antibody profile that is associated with the development of pulmonary arterial hypertension. Not to say that the other forms can't get it, but yes, anti-centromere certainly makes it more likely that this is pulmonary arterial hypertension rather than the other types of pulmonary hypertension, for example. In trying to prevent this, unfortunately, we don't really have any great preventative strategies. Trying to, there's nothing that I can say that if you do A, B, and C, you definitely won't develop pulmonary hypertension. We're still trying to work out the underlying molecular pathways that determine why your particular arteries start to narrow. And it's not everyone, as I said, with scleroderma that will develop it. It's not even everyone with anti-centromere positive scleroderma that will develop pulmonary arterial hypertension. So until we know at a more personalized level, and there's such a thing called personalized medicine, where we're trying to work out, is there a specific genetic underlying signature, if you like, within a patient that can tell us, yes, you're at higher risk of developing it than someone else here, and then pay more attention to that patient to try and really identify the condition at an earlier stage. I think that's where screening comes in, to really pick it up at an earlier stage, because picking it up at baseline, certainly intervening with our drugs, have suggested that can delay progression of the disease.
Thank you very much for that very helpful response, Dr. Church. Question from Jennifer. Jennifer asks, hi, I have pericarditis and systemic sclerosis. Also, I have COVID. Now breathing is getting worse. I am due to see my doctor next week. Can I ask for pulmonary hypertension to be determined?
So yes, so I'm sorry to hear you've had COVID. And yes, I mean, unfortunately, patients with scleroderma can get breathless. Patients with scleroderma and COVID, you're throwing in another reason to be breathless, and trying to investigate the underlying symptoms. Often will need a number of tests, but without doubt, one of those should be to look for pulmonary hypertension. So I'd be absolutely saying to your doctor that you should be looking for not just COVID effects on the lungs, but also should be checking out your heart to make sure you haven't got early pulmonary hypertension, and that we can do something about. And it's not until you, unfortunately, A, think about this as a condition, and B, start looking for it, that you'll actually pick it up, because as I showed you right at the start, it can go on for years and years and no one actually thinks about it, because it's quite a subtle disease. It's not like you turn up with a big placard on the top of your head saying, I have pulmonary hypertension. That's not the way this disease presents, and it's often quite advanced before you get to the point that the disease manifests itself with more severe symptoms. So listen, Jeff, I hope it all turns out well. COVID can affect the lungs. We're starting to see that. We know that. But with your underlying condition, pulmonary hypertension is absolutely a key diagnosis to make sure you've not got
Thank you very much, Dr. Church, for that very comprehensive and helpful answer. And we hope that helps, Jennifer. Another question from Tanya. So Tanya asks, do patients with more severe Raynaud's have higher likelihood of developing pulmonary arterial hypertension? And do you recommend regular Raynaud's medications, nifedipine and losartan, etc., to minimize risk of developing pulmonary arterial hypertension?
Well, they are fantastic questions. I actually, I'll put my hand up here. I don't really know of any direct association with the severity of Raynaud's and likelihood of developing pulmonary arterial hypertension. But I will go and look that up actually in the literature, because it's a great question. What I can tell you is that Raynaud's out with scleroderma is more common in patients with idiopathic pulmonary arterial hypertension. So that's where you have this narrowing of the blood vessels, but we've looked for scleroderma, we've looked for other reasons, and we can't find it. So you have narrowing of the blood vessels, we call that idiopathic disease. And we do see a more common association with it. But what I don't know is whether the more severe your Raynaud's is, the more likely you are to have pulmonary arterial hypertension. But it's a great question. There is more evidence coming that pulmonary arterial hypertension in its own right might be a systemic disease. It doesn't just affect the lung vessels, which we've thought of for many years. The treatment, I've got absolutely no problem giving calcium channel blockers, the nifedipine, etc., to try and treat that. In fact, many rheumatologists often use the pulmonary arterial hypertension medication like sildenafil, tadalafil, or bosentan to try treat the Raynaud's. I know some that use intravenous iloprost as well to try and treat that. So there is certainly an overlap between the treatments and the pulmonary hypertension treatments. But again, I don't think I've seen any evidence to suggest that if you take these calcium channel blockers or the other disease-targeted therapies, that it actually stops you getting pulmonary arterial hypertension.
Thank you, Dr. Church, again for your excellent response. Jennifer has come back to us with a follow-up. Jennifer states, also with COVID, I have waited 2 years now for an echo done on my heart. Can I fast track this in any way, as I have concerns? So unfortunately, Jennifer, you are not alone. I know of many big centres in Scotland that the rheumatologists have been contacting us saying that the Echo department are pushing back, saying that we cannot accommodate routine screening echoes because they're trying to prioritise for other, other conditions, and because of COVID, social distancing, the amount of patients that you can get through in a day have dropped off. I think it's unfortunately a reality that we have. All I can say is that you have to just be very strong-willed and really fight your corner to get the echo done. It should be more easier to get that as time goes on, hopefully, and fingers crossed COVID starts to wane a little bit. Certainly in Glasgow, we're starting to do extra waiting list clinics for echoes to try and catch up with the backlog. But it is a real problem. I mean, I think if you can't get an echo immediately, then certainly doing other things such as the ECG, and your GP can organise that, or a chest x-ray, that at least is something. It's not maybe as good as the echo, but it's certainly something to try and help. Certain GPs can also do blood tests now. This is where it gets a bit technical, called BNP. That's a molecule that is elevated in pulmonary hypertension. It's also elevated in other diseases, but it's certainly one that if I had an elevated BNP, I'd certainly be trying to fast track for an echo. Lovely. Thank you very much, Dr. Church. And thank you again, Jennifer, for your question. And we do wish you all the very best. Barbara has asked a question. Barbara asks, I always have a raised pulmonary arterial hypertension. but when I have a right heart catheterization, I have been told I don't have a raised pulmonary pressures.
Okay, so I'm not sure I entirely follow that, because if you have raised PAH, I take that to mean you have a diagnosis of pulmonary arterial hypertension, and that's usually done at right heart cath. Now, what we could do, and that's possible, we've seen that before, where you do an echo and the pressure is elevated on the echo, but when you actually come to do the right heart cath test, the pressure is not high. That is seen, not a lot, but it is a feature, and that's why we do the right heart cath, because echo can actually over or underestimate the pulmonary pressures. So if Barbara's talking about that at echo her pressure is high, but when we come to do the right heart catheter it's normal, that could be one explanation, because the echo is not a perfect test. You've got to remember that it's subjective to someone finding a good spot on the lung, on the heart, to measure the pressure, and that can be difficult in certain patients. It can be and lead to artifact and the wrong, incorrect readings. So I apologise if that's not what the question was about, but I think that's the one that I can try and answer, Ollie.
Yeah, excellent. Thank you, Dr. Church. And some lovely feedback from Anita, who just says, thank you so much, very informative.
Pleasure.
Yeah, lovely. Helen asks, can we do anything to prevent pulmonary arterial hypertension?
Yeah, the $1 million question. Not really. I mean, it's not something that is easily preventable. I mean, effectively trying to keep as fit as possible, avoiding things that are going to lead to problems with your lungs anyway, i.e. smoking, excessive alcohol. Those are the things that would just go along with a holistic approach to your scleroderma anyway. There's nothing specifically that you can do that will prevent you developing this complication, unfortunately.
Thank you, Dr. Church. Just a few minutes to go now before the end of the session at 3:55, and it's great. We've certainly got through the majority of the questions, so that's great. Laura asks, the echo showed I have impaired relaxation of left ventricle. I have been told, as everything else with the heart looks fine on the HR CT, then there's nothing to worry about. Is that the case?
So this is, so impaired relaxation of the left ventricle is a condition that we are seeing increasingly common, not just in scleroderma, but in the general population. It has another name, or it's got lots of different names, diastolic dysfunction. But effectively what we're talking about is the left side of the heart becoming stiffer. And in certain conditions or certain cases, that can then mean that the heart is not emptying the blood as efficiently and as effectively as it should be. And the pressure within the left side of the heart can can be raised, and that feeds back with fluid into the lungs. So you can get a condition called heart failure with the pulmonary edema, where the fluid is actually gathering in the lungs. However, usually when that happens, you would see evidence on the CT scan of fluid in the lungs. And if you're not seeing that on the HRCT, then that's reassuring that the heart is pumping effectively and efficiently. It doesn't mean it will always do that, unfortunately. And if you did develop symptoms such as breathlessness, lying flat in the bed, or waking up through the night with more breathlessness, then your doctor should reinvestigate at that time, and you may need to see a cardiologist or increase your water tablets, for example.
That's an excellent question, excellent response, and an excellent question. Thank you very much indeed. There is still a couple of outstanding questions, but we've come to the end of our session, so I'm really sorry we're not able to answer them at the moment, but we'll certainly look to get to responses for you. So all that goes for me to say is, again, thank you so much to Dr. Church this afternoon for his time and for an excellent presentation, really informative. And thank you so much to our community for supporting and joining the breakout session. So it's your coffee break now, so please do enjoy the networking and the exhibit space and the health and well-being zones. And the coffee break will be from 3:55 till 4:10, and then we look forward to welcoming you back into the auditorium for the final session, What Does the Future Hold, with our panel of experts, Professor Chris Denton, Professor Elizabeth Volkman, and Professor Francesco Delgado. So thank you very much, everybody.
Thank you, and thanks for the opportunity, Ollie.
Thank you, Dr. Church.